let's start our session about the presidential initiatives in cancer screening. I have the honor to present Professor Dr. Ahmed Morsi. He is speaking about the presidential initiatives of cancer control in Egypt, access to personalized cancer care innovations.
Thank you for having me today here. It's my pleasure to give a quick perspective about the presidential initiative regarding cancer care. We're going to talk today about 5 cancers. We started in 2019 with the cancer breast in the Presidential Initiative for Women Health. And in July 23, we were able to add 4 more cancers to screen: lung cancer, colon cancer, cancer prostate, and cancer cervix. What we do is that we try to do an early detection, a modified, highly selective early detection campaigns to be able to reach cost-effective and to be able to use our capabilities to reach the largest number of the population. However, we also need to understand that the initiatives is a program that was based on the idea that the strategy for healthcare is the universal health insurance. It's the ultimate strategy. Also, prevention and early detection is the way forward in the MOH. So based on this, we decided, or the government decided, through the strategy set by the president, that we need to find a solution to fix the problems, the healthcare problems that we are facing until the system is completely implemented for the universal health insurance. Based on this, a criteria of the problems was set. The first one was virus C. Virus C was the biggest health problem in Egypt in 2018. The initiative was done. It was done in 7 months and was able to reach 62 million person in the population, and Dr. Ihab was a major part in this initiative. And with the success, we built on the success of this initiative, and we built on the success of the relationship that was done between the population and the primary health unit, which is the most important aspect of success of this initiative. What we do is that we followed the idea of working scientifically. We have a scientific committee and an executive office for each of the initiatives. We started with clinical breast examination for a questionnaire, followed by a clinical breast examination for breast. Then we do for lung cancer low-dose CT, which is practically the standard of care. In colon, we do FIT testing, followed by colonoscopy. In prostate, we do PSA, followed by MP-MRI, according to the result. However, we don't start from the cutoff of 4. We increase the cutoff because we're trying to find the patient that needs intervention, so not to burden the system with patients, and then we end up doing only active surveillance, which would be more burden on the system. Based on this, we did a questionnaire. This is the high-risk questionnaire, and a major part of the initiatives that's been disregarded is that the initiatives are completely paperless. Everything in the initiative is done on a system, it's done digitally, and you cannot move forward with the operation unless you completely finish documenting the step that you are in. What we do is that we gather demographic data, medical history, and family history, and then we upgraded this with the new initiative that we're able now to have complete medical data about the patient journey through treatment also. So it's not only for the population, it's also for the patient within the cancer centers. Again, quickly, this is the cycle, and this is a patient medical report actually showing each patient and the step they are in. So what we do is that we do the questionnaire, then we refer, more diagnostic, then refer to the pathology, and we had to upgrade every point of this, and then we were able with our team to set the MDT. It became a fact, it became a culture, and it's one of the things that we're very proud of. Then the treatment plan is set, and we learned from the initiative for presidential for women health in the cancer care initiative that we have to follow closely the treatment plan, the treatment delivery, and the result of each decision of the MDT is followed so we can assess later on this data. Again, this is quickly the reports. This is the work of a team of 40 pharmacists from the MOHP. They are in the office for follow-up for the presidential initiatives, and they are the core for sustainability for this project. They are the one who are doing all the job. What we try to do in the management is we try to reach standardization for the protocols, and the main idea of the treatment protocols is that people are treated in any point of Egypt the same way. They receive the same service. The treatment protocol means that you have protocols for surgery, you have protocols for radiotherapy, you have protocols also for screening and for diagnosis, for pathology, for biopsy taking, for fixation of the sample. This is what we mean by standardization. So you would have the same journey and the same aspects everywhere. In order to be able to do this, you need to follow up. Digitalization is major for follow up and to build on for the future to do, to be able to do research and to be able to follow the operational, the operation in each point. And the last thing is the idea that multidisciplinary is the base of a successful treatment plan. This is the three main strategies for management. In order to do this with the new initiative, especially for lung and colon, we were able to do an integrated pathology lab. An integrated pathology lab means that you receive the sample, you do the anatomic pathology, or maybe the clinical pathology for the blood sample, and then you go through the NGS process, and the NGS has a dry lab and has a wet lab, and this is the flow. This lab is now set. It's in the verification process. Then it will be going through the process for CAP accreditation, and it will be coupled with an academic partner in the coming period. Also, this lab will be the basis for approval for any molecular testing to receive any management or any treatment within the MOHP and probably also the HIO. So what we're trying to do extra in this lab is that we're trying to provide a CGP, a complete, comprehensive genomic profiling. What we have now is a capacity of 1,800 samples that we are able to reach 18,000 samples. However, we are making it on phases because of the cost. What we try to do is that we try to partner to do a PPP with the private sector, and we try to have the support of the pharma companies. We already have around 1,000 or 1,200 samples that already have been, I'm going to use the word donated by the pharma industry. So in the women health, this is the numbers for the last day of September. We reached 42 million examination for 20.8 million women. What we call a periodic visit is that means that it became a targeted screening, not an opportunistic screening. So you have a date that you have to go to. If you miss your date, you're being called, and we keep following on you until you come and take your visit. We were able to reach 12 million women, and the unplanned visits shows that the system is ready to accept people whenever they have a problem. So if you feel you have a problem, even if you finished your visit and you're not scheduled for a visit, you can come and we will do the examination for you, and you will be reported. And if you need anything, everything is done for free. A quick look about what we did. What we call the hospital examination is basically an expert examination with an oncologist or a surgeon. We have reached 500, almost 500 or 800,000 visits. We have done more than 3,000 radiology examination. This is very important because the radiology examination here is the diagnostic examination, which means that each of these examination is coupled with a radiologist who's an operator. He's an interventional radiologist for breast, or she's an interventional radiologist for breast who would do an ultrasound coupled with the mammo. We are able to do 44,000 pathological tests. In order to do this, we increased the capacity from 4 labs to 22 labs or 21 labs. And through the system or the patient journey of the screening, we have 22,000 confirmed breast cancer cases. However, we treat more than this, and this is what we're going to show you. This is for the year 23. Out of the 42 million, we have 11.8 million visit in 22 to 23. We start our year on the 1st of July, of course. The total hospital examinations are 90,000. The total radiology examination are almost 60,000. We have 8.5 thousand pathological tests, and we have confirmed 6.5 thousand breast cancer cases. This is a quick look about the situation before and after, and I'm not going to go all through it. However, this is the different aspects of the campaign. What's important here to say is that we worked through the pandemic. We did not stop. We did more than 13,000 visits through the pandemic. We also start from the age of 18 to increase the culture and to set the culture that clinical examination and, that early checkup and early detection is a culture for any NCDs and for the population. The total number for diagnosis before the initiative was 141 days. We reached 21 days. This is an average, of course, and in certain centers we are able to reach 11 days. The pathology labs were 4, now they're 21. And the total days from the first visit to the treatment, to the start of treatment, used to be 270 days. We have reached 49 days, and this is significant. We'll show later why. Of course, everyone by now knows that we were able to decrease the staging and that we increased the number of patients at stage 1 and 2. We were able to be present in the 27 governorates, over 3,500 units. The average size decreased. This is the data for the first 2 years, and Dr. Luay, Dr. Ahmed, and Dr. Ahmed Hassan are now upgrading the data for the 4-year update. Of course, there is a huge effort that was done in surgery, and this is one of the things that's not complemented enough, in my opinion, that the surgery and the effort that was done for surgery to decrease the number of mastectomies and increase the conservative surgery, especially with the sentinel lymph nodes, especially that we don't have a standardized system yet for this, had been done. And again, we're always debating the numbers that we want to reach. A global breast cancer initiative was set, and it was backed by the WHO, and these are the main pillars for it. The first pillar for health promotion is that 60% of invasive cancers should be less in stage 1 and 2, and we have reached that. The time for diagnosis should be less than 60 days. As we have seen, we have 49 days. The comprehensive cancer management, that 80% should undergo multi-modality treatment without abandonment, which means that they are able not only to take the decision, but they are able to receive their treatment and receive it on time. We can claim that we are able to do this in breast cancer. However, there is a huge challenge in radiotherapy, of course, and we already the government already has addressed this. There is a lot of machines that are coming in the way, but of course we know why they are late. This is very important because we've been asked about this a lot. What we have seen in this slide is a conclusion of a study that was made for the cost effectiveness and the budget impact of the initiative. Although we have to always remember that, as we have seen, the initiative has many objectives. One of them is increasing the infrastructure and developing the scene for the universal health insurance. However, we still prove to be not only cost effective, but we are cost saving. We were able to save 1.2 billion pounds since the start of the initiative. I'm going to need more time, please, so please open the time for me. A quick look about how the system goes. So you go through the initiative. What's very important here is to show that now it's embedded in the system, that the team is a female doctor, a female nurse, a data entry specialist, and a healthcare supervisor. All are present in each of the 4,000 or the 3,500 primary healthcare. There are mobile trucks that are being upgraded now with the effort of the UPA and Dr. Nuran, of course, and we are able to upgrade 10 of our 12 units, which are very important to reach for the outreach program. This is only to show that we have an SOP set, and this is very important with, of course, the follow-up team, because this is the sustainability of the program. This shows you that the program is not going anywhere. If it's written and if there is a system and there is an outcome, the initiative is always there. A quick look about the system and a quick look about what we do. This is the certification for Dr. Reem's Center for her pathology lab. It's the first CAP accredited pathology lab in Egypt, and we thank her for her effort. The next one now is being set in Asr Al Aini. Cairo University, and the third one is in the CDC in the integrated lab. Again, a quick look about what we do. When we set the initiatives for women health or even for the cancer initiative, we use pillars that we built on it, and this shows you again why the initiative is not only about early detection or setting protocols, it's about upgrading the infrastructure and the system, and these are the 8 pillars. And what we see here is that based on a personalized cancer care alliance that was set by the WHO, again, they defined 5 Ps of how to be patient-centered program, and you have to be predictive, preventive, you have to be personalized, you have to be preemptive, and you have to have the participation of the patient in the program. And this is our next year's agenda, how to have the patient participate in the decision and in the system and in the audit of the system. Major part for the sustainability is the effort done by the team for the training, and with the help of Dr. Ihab, who's here with us today. These are the numbers of the people that we're able to train, and as you see, we start from the data entry specialist at the primary health unit, but we also reach the highest technicalities with the physician, with the surgeons, with the radiologists, with the pathologists, and everyone, even the nurses in the healthcare. And we're going to start next year the survivorship program and also the communication skills program to try to make the patient journey more easy on the patient and on the caregiver. What we also did is that we found a lot of people who can work a lot and have a good experience, but they're not backed by an academic degree. So we tried to set, and we did actually set a diploma with Northwestern, focusing on breast cancer in all aspects of breast cancer. They started, each round takes 6 months, and the first graduates are already out, and we're going to do the graduation ceremony in the coming weeks. With the help of our team and with the efforts of Dr. Luay and his team, we were trying now to do what we call the DECIDE trial. It's a concern with this machine. It's called an iBreast machine. It was the idea of Dr. Hamdi Abdelazim, is that we need, if we are using clinical examination, we need to find a way to enhance the examination, to decrease the false negative and decrease the burden on the system by decreasing the false positive. This is one of the methods, and we're trying to test it operationally and scientifically through the DECIDE trial that will start in, I think, 5 to 6 centers in the coming days, pending the IRB approval. We also extended our efforts to Kenya and South Sudan, and we're already working with Kenya right now. The convoy to South Sudan, again, was done by Dr. Nuran and Dr. Luay Qasim. As for the cancer initiative, we have set 3 major strategic outcomes or objectives that we want to reach, which is early detection for these cancers, which is not a very easy job, and reducing the late stage patients. This also will affect the expenses spent by the payers. And finally, we are going to be part of the cervical cancer eradication that was set by the WHO. And this is something that we can do because our numbers show that we are very close to claiming eradication. However, these numbers have to be verified. The system has to be set. We have to also work on the HPV. Maybe our numbers are good in cancer cervix, but the numbers in HPV are far worse than expected. A quick look about what we did in the past. In 9 governorates, we started in July, and we were able to do until the date here changes to the 29th of October. We have done 1.8 or 1.9 questionnaire. The questionnaire takes you through a journey based on age expectancy, comorbidity score, and other risk factor assessment, to which, if you have a risk to one of these cancers, and these are quickly the numbers of the malignant cases and the benign cases, and this will show you something very important, that we can claim that prostatic cancer has good infrastructure for diagnosis. However, lung cancer is extremely defective, and this is one of the KPIs that we look for, that we try to upgrade. So this number should be followed in the coming year. Also, what we see here is that the participation of male is very low, and this is also one of the things that we are working on through our awareness campaigns. What you do is that you go with your national ID to do registration, but we were able to set that you can do the questionnaire over social media, you can do the questionnaire with the convoys, you can do the questionnaire with the through calling the call center, which is 15355. صح الرقم ده يا دكتور إيهاب ولا إيه؟ الكول سنتر كام؟ 15335 and you can call them, ask them to do the questionnaire for you, and they will fill it for you. After you get the questionnaire, if you need to do an extra step, you are asked to go to a certain place and you are directed, but you're also in the system and you're being followed by the team. If you don't go, we keep following you. We have more than 100 seats in the call center. We do send text messages, and the follow-up is ongoing, because still this is a major part of increasing awareness, to keep calling people and show them that you have the right to do your checkup. A quick look about the system, and then what we do in lung cancer is that we also added a smoking cessation campaign, because it proved scientifically that it's the most important thing to do to decrease lung cancer is the smoking cessation campaign. But in lung cancer, we are very standard to the scientific world and to the guidelines of public health. We do a low dose CT in the age group that's directed, and then you go through what you need later. However, we have two challenges in this area. First one is awareness. Second one, how can we screen non-smokers? As for colon cancer, we do FIT testing, but we also have another step here, is that if you have a bleeding per rectum, you go directly. If you complain or claim that you have bleeding per rectum, you go directly to colonoscopy. As for PSA, we did a little bit of changes based on studies and papers that were done in Europe. We increased our cutoff to 10. As you see, from 4 to 9, you redo the test after 6 months. When between 10 and 20, you do an examination by a urologist, and then you're sent to do MRI, MP-MRI, and this is actually a bottleneck that we're trying to fix. As for if you're more than 20, you go for trust biopsy, and this is why you have seen that we have a lot of cases that are positive. These cases, this is 100% of cases referred to do biopsy. So 100% of cases to do biopsy were positive, and it's because all of them are above 20. However, 75% of them are below, are stage 1 and 2. 75% of them are early, are stage 1 and 2. As for cancer cervix, we've done something a little bit different, because we're trying to test the system. So we worked with high-risk patients, and we set some data and some question to define the high-risk patients, and we were able to reach part of the community. However, we are expanding this to a national campaign in the coming period. We're also exploring the idea of doing a self-testing through a vaginal swab. These are quickly the numbers. As you can see, 1.2% of the total questionnaires are referred to lung cancer, 6% are referred to colon, cancer prostate 4%, and only 0.3% go to do a high-risk examination for cancer cervix. This is the numbers for male and female. And this is our quick look at the numbers to show you what this is, an operational way of assessing the system. So each number of this shows you where is there defect, where is a bottleneck, how can you help, how can you increase the capacity, if you need to add machines, if you need to teach people more, if you need to train people more. And this is very important in the first 2 years, because by year 3, you should have an upgraded, adequate infrastructure for management of these diseases. The final thing is that one of the pillars were cancer centers of excellence, and in the past 3 years, we've been working to be able to have Gustave Roussy as a center in Egypt as Gustave Roussy. So Gustave Roussy is set in the final, now we are in the final part of the contract between the government and Gustave to be set in, to be hosted by Dr. Reem in Dar es Salaam, hopefully. And this is just a quick look, a quick teaser about what's going to happen. And let's just go through it very quickly. So the number of beds are proposed to increase from 154 to 400 beds. including, of course, all beds except the dialysis beds. Thank you so much for your time, and sorry for taking more time.
So thank you, Ahmed. Very comprehensive. I think we'll call on the next speaker, and then we'll take questions in the end. I'll call on Dr. Ahmed Magdi. Dr. Khalil Abdulaziz, talking about digital transformation in cancer care.
Thank you, dear professors and chairpersons. It's an honor to be with you to present some ideas of how digital transformation can transform our way of managing our patients. Some of these ideas can be incorporated or actually incorporated in our practice, and I think as part of the presidential initiatives, we try as much as we can to incorporate these transformations in our practice to improve our outcomes. These are my disclosures. So first, what is digital health technology? It's an umbrella that incorporates everything that we use in digital health in our practice, from the electronic health record to patient portals, mobile health applications, wearables like our smartphones and smartwatches, and all what is incorporated in telehealth, from clinical visits to virtual multidisciplinary teams. So it can be included in an intervention, or to evaluate an endpoint, to evaluate the delivery or monitor the intervention by itself, or to streamline or simplify what we actually do in our practice, in our everyday practice. So the power of digital technologies and data, it's to use all the technologies that we have, from high performance computers to artificial intelligence, Internet of Things, which is the ability to attach something like your television and AC and be able from outside your home to activate it or deactivate it. So it is the use of internet to control things that were not used to be internet connected from at the beginning. Cloud computing, and again another challenge about this, the privacy and how the safety of this technology. Mobile health is increasing, wearables, telehealth, and definitely 4G and 5G implementation. So what we need is we have an improvement in the technology in our everyday life, from everything we use, from Uber to how we order our food, and this technology can be implemented in our healthcare practice. But as doctors, we are very conservative. We need to feel safe for our patients and our patient privacy, and therefore we need innovation in the policy to come in line with the innovation we have in digital and technology. So digital technology can be a communication or something, an interaction between the patient and the clinician, or clinician and the clinician. And it may be synchronous at the same time. So for example, telehealth, which can be used a lot for patients in remote areas. So between the patient and the clinician, and it can be asynchronous between the patient and the clinician, like electronic patient-reported outcomes, very important to detect the symptoms and toxicities of treatment and chemotherapy, for example, in our practice. The mobile health applications, the portal messaging, and e-consultation, which is different from telehealth, meaning it's not a live consultation. And between clinician and clinician, definitely we have virtual MDTs, we have clinical decision support softwares and communication devices that allows us to have a second opinion for our cases, and asynchronously we can have electronic health records and other types of digital solutions that may help in this setting. So I will focus on the most important parts and how we can incorporate in our practice. First one is the remote patient monitoring and electronic patient reported outcomes that have been implemented in general medicine, for example, in recording and reporting of blood glucose level. And you can see that from the early 2020s, we have an increase in the endorsement of this technology in general medicine. And definitely the issue is to overcome a challenge that we all know, for example, in our practice in chemotherapy, that the patient, if they have a problem, they are reluctant to contact the physician. They are reluctant to go to the hospital for a non-scheduled visit. And definitely they have problem communication with their physician, and when they go to visit their physician, they have limited time and they forget to discuss what happens between the 2 cycles of treatment. So what we can do with electronic patient reported outcomes is to have an electronic reminder asking about their symptoms, daily symptoms, and they can report what they have. And definitely this messaging can also achieve to increase the detection rate of alarming symptoms and alarming signs, therefore having some sort of electronic alert to the physician which with a feedback mechanism. And as you can see from an experience, for example, from the MSK, where they ask the patient to report their symptoms between the clinical visits, the level of adoption was around 75 to 80%, and it was equal for computer users and non-computer users, because it is always what we say, but our population will not be able to use this technology. So no, non-computer users in United States, and whoever of you have visited United States knows that we have sometimes they have a population that may be very similar to our rural population. So, and it led to an increase, an improvement in the quality of life in comparison to the usual care. And this improvement in quality of life was also correlated with a decrease in the level of hospitalization and a trend for overall survival benefit for these patients, because you detect the symptomatology and the complication of treatment earlier. So, but we have challenges in implementation of these types of technology, definitely. It has to be integrated, whatever the way the patient reports, it has to be integrated in a portal. It has to be the ability to have some report. So the physician and the patients need to have a feedback when they enter the data. If nothing happens, then he doesn't feel the feedback mechanism for them. They must have tips. So it needs to have also feedback in terms of tips how to cope with the toxicities and symptomatology and alerts, and ability to view the trends of what's happening to me as a patient, if my symptoms are improving or decreasing. And for clinician, again, it has to be integrated in their actual electronic health records, which may be different between hospitals. This is why we need some technologies that are cross-platform eligible, and they need to have a way to communicate that is not disruptive to their workflow, because we are very busy in our practice. Artificial intelligence is definitely something that is coming very quickly in our daily practice, but it's actually been there for a long time, specifically for drug discovery and molecular creation of molecular patterns to try to focus on mutations that will be detected from molecular testing. But we can use it for medical simulation, chatbots, in improving the imaging technology. And this is one of the things I think we will be working on in our initiatives: the medical research, patient care, disease diagnosis, and personalized treatment plans. And as you can see, you can use some simulation, 2D and 3D simulation, to help the surgeon for the training. We have challenges in training in some very highly specialized surgeries, so it may help in 3D visualization and 3D reconstruction to help our surgeons perform better. And it can also be help into the improvement of personalized medicine, because it allows us to analyze a lot of big data and molecular data that we have from the analysis of our patient, and therefore see a trend for the types of mutations that may be more specific to our genomic background as Egyptian population and African population. So definitely the COVID-19 has improved our endorsement to these technologies by improving or endorsing on us the telehealth capabilities. So we had challenges in terms of diagnosis because of the increased medical complexity, especially when you have patients with COVID and you don't know if it's a lung nodule or it's an infectious nodule. So increasing the decision support tools that allows us to check quickly the guidelines for specific nodules, and also use artificial intelligence for improving our detection rate and suggestion of potential malignant potential. And indeed, again, it can be used in the care and the usual logistics to improve our planning and automation of some of our daily practices with our patients, therefore decrease the time that the oncologists need in their practice. So we can use it also in medical education. I think we need to leverage the ability to use social media to engage learners. The pattern of learning of physician is extrapolated from the general population. It is the same. We are more into social media platforms than we are in the usual way of reading literature. We can use virtual reality again and augmented reality for training and specifically for surgery and experimental learning. And we have to also, maybe it's time for us to understand the concept of blockchain technology, which is the ability to leave pieces of information not on a single computer but on different computers. It can be helpful, for example, for the recording of exam data in our educational process. It has been used a lot in fintech for the safety of the financial data, and I think it can be used also for the safety of the exam data that we use for evaluation of our students. And definitely the use of generative AI such as GPT, which is a language model, it needs to be used wisely. But I will show you that it is actually something that have a potential. We all know the story of the mother who had a child with a very rare disease and has been looking for a diagnosis for a long time with physician, and then she entered the symptoms on ChatGPT and it gave her, it suggested, and this is what is important, it suggested the right answer for the diagnosis of her child. And we put one of the exam cases, one of the difficult cases of ependymoma on two different language models with an MCQ. And as you can see, one of the most common, ChatGPT and Google Bard. And this is an actual trial I did for this presentation. It gives the correct answer and explaining why it chose this actual answer. Again, it has to be used very wisely because it has errors that we are not aware of, and this is the big issue, but it can be very useful to suggest and help us in our daily practice. Again, we do also mistakes as human beings, so we focus on the mistake of AI, but we forget that as human beings we miss sometimes our diagnosis and we do mistakes in our management. In diagnostic imaging, again, it's a very omnipotent in CT scan and X-rays, and the ability again to suggest malignant potential of lung nodules and other types of screening methodology, like also in breast cancer. Virtual reality again can help, has been used, and this is one of studies that has been published 2 years ago in the ESMO, to decrease the anxiety of patients, because patients while receiving chemotherapy are very anxious. Sometimes they are in a clinical setting that by itself is causing sometimes nausea and anxiety. And the aim of the study was to put them in a virtual reality pattern that is relaxing for them. But does it actually work? You can see from these values that has decreased all the endpoints I've been looking for in tension, depression, anger, fatigue, confusion. So it has a statistically relevant improvement in all of the endpoints they have been looking at. Last but not least, the medical mobile applications we use in our everyday practice, we need to enforce or not enforce, but maybe push our colleagues to use it more. Things like UpToDate, Doximity, Medscape, and all the tools that we use in our daily practice that may facilitate to decrease the medical error and increase our ability to perform better in our practice, because we know that these electronic applications can enhance the medical environment, specifically if you use it with Internet of Things that we've been talking about, implementation and enhanced data management, improve the prescription alerts and the medication errors that we do a lot, which is one of the major killers worldwide, which are the medication errors and drug-drug interactions, decrease the hassles of payments and increase the facility to access to care, minimizing the risk of misdiagnosis, again with the use of artificial intelligence, and improve the patient engagement, again through a potential 24-hour communication or feedback mechanism with our patients. But it still has some limitations. Implementation, physicians need it to see that it is saving time and it is efficient. It needs to be easily accessible and compact overview on their mobile applications, and it needs to be sure that it keeps in the patient safety and quality of care. Internet of Things, again, can be used for remote monitoring of our patients in terms of heart rate and symptomatology and patient-reported outcomes, but also in while using wearables. As you can see, using these wearables can improve our ability to preserve this information that happens while the patient is not in front of us, and then being analyzed by the big data and high computing system for the doctors to be able to have a chart of what's happening to their patient while they are at their home. And definitely we have ethical consideration while managing the issue of digitalization in cancer care, because we need to be sure that we are keeping the patient data privacy, and we have already regulation and acts like HIPAA Act that can enforce and guarantee this patient data privacy. We need to have informed consent for the data utilized with big data analysis, and also the dilemma of data ownership and bias of AI algorithm that needs to be well looked into by our policymakers. Again, the regulatory challenges is that it's a very complex regulatory, because it's not always a technology that we understand well, and regulations and policy needs to be to act quickly, to be in clear continuity with what's happening in AI. And we have already digital health initiatives by the FDA, for example, which we can look into and see how we can copy. And we need to increase the interoperability, because if you have an application that works only on Apple or iOS and doesn't work on Google or doesn't work on Windows, this is an issue. We need to improve the interoperability between the systems and the global harmonization, so that we can transfer the data from a system to another. So again, this is an AI generated image about digital transformation in cancer care. As you can see, the image is very beautiful, but AI was not able to write any word of them in a clear way. This is again one of the limitation. So we have to understand the limitation of technology if we want to use it well to our benefit. Thank you very much.
Thank you so much, Dr. Khaled. And now it's my great honor to introduce my dearest friend and older brother, Dr. Luay Asim. And let me congratulate the whole presidential initiative of Women Health team, that we are all truly and deeply honored to have the great work of the 2-year data of the presidential initiative of Women Health to be presented for the first time in the biggest international oncology cancer conference, the ESMO, as a great successful experience that support other countries that are taking the same steps for screening early detection. And now we are having the talk of Dr. Luay in the title of, 1 minute, sorry. The power of big data on research and publication, breast cancer screening as an example.
Thank you very much, Dr. Nermeen, for the very nice introduction and for organizing this session. Hopefully we'll have the slides soon. That's a big topic to cover, I know, and not in the focus of many oncologists. However, I think it is an important point to cover, to be aware of. Big data in general, it offers many research opportunities for cancer care and for medicine in general. These are my disclosures, and I will not go into very technical details of how to handle big data yet. I would give some insights on 3 stories related to big data. First of all, do you know who this man is? This is Dr. Ulf von Euler, and in addition to his very difficult to pronounce name, but he has a major impact on our life. He is Swedish, he's born in Sweden, and he started his medical career. He went into Faculty of Medicine and started his medical career, wishing to have an important impact on clinical and translational research. Well, it wasn't called back then translational research, but he was into laboratory work. Yet, at the first start of his career, he worked as a gynecologist in a community clinic. He wasn't very happy with that. Again, he wanted to work as a scientist, a researcher. But he tried to use his researcher's mind into caring for his patients. And he was just delivering babies all the time. He noticed when running through the files that some ladies didn't have very good uterine contractions. That was in the beginning of the 20th century, by the way. So he didn't know what helped some ladies to have very good uterine contractions and delivering their babies effectively and fast, while other ladies did have their uterus lax during the contraction. Well, he run through every single, through the files. Well, there were all paper files, and he did some tables manually, and he didn't find any possible hint of the reason, except that ladies from the poor region surrounding the hospital, they had better contraction, better uterine contraction. While the ladies from relatively richer part of the town, they had poorer uterine contraction and longer delivery and more likely to obstruct. He didn't get what is the reason, but he went into a detailed history based on that data, and he noticed a consistent observation for the poorer ladies compared to the rich ladies. The poorer ladies or ladies living in a relatively lower socioeconomic, they had consistent and continuous sexual intercourse till very near in the delivery, while the other ladies did not. And when he retested that history of sexual intercourse in relation to the uterine contractions and the easy delivery, he found that was the most significant part, more than the socioeconomic level. He assumed that there is something in the seminal fluid that was related to uterine contractions. And as back then, all the semen was thought to be only secreted by the prostate, so he called the newly discovered chemical compound prostaglandin. That was how was discovered. Later on, this discovery opened the door for almost a whole pharmacological books and of many of the drugs today that are based on prostaglandins. He left his work in gynecology and he kept in his lab, and he finally won a Nobel Prize in physiology, in medicine, by discovering another very well-known compound called noradrenaline. Again, he is the one who discovered noradrenaline. So this guy really discovered most of the internal medicine curriculum. The second story is about cancer registry. Despite now we think of cancer registry as something that's easily available, easily targetable, yet in the 70s it was a science fiction. Even the start of a national cancer institute at its essence, like a big institute with a big fund to collect data and to do cancer research, it started in the early 70s by a push not from physicians, but from the patient advocates. And the first National Cancer Act in the United States was issued in 1971 just to give adequate fund to a big institution to start doing cancer research. Just shortly after that, started the SEER database, the Surveillance, Epidemiology, and End Results Program, initiated by the NCI of the United States. And it based on a very simple data capture tool, a paper form that every doctor in the NCI started only in the hospital, because even in the NCI, that institution that was built for cancer, to do cancer research, there wasn't a unified cancer registry. So it started by using a unified cancer registry, getting only the type of cancer, the organ where the cancer is, and the stage where the cancer is. In addition to when does the patient dies. So that's the end result. So from that started the first accurate statistics of cancer staging and cancer survival. In 1992, it did establish that as globally in the United States within the CDC control and prevention centers in the whole United States. Again, that started only in cancer centers, in the NCI, expanded to the cancer center, and then it expanded to any patient treated in the United States for his doctor to fill this data. Of course, starting from the 90s, it's not a paper form anymore. It's a computerized form. I did a PubMed search yesterday for SEER database. I'm looking for publications that are based on SEER data. And you can find that last year alone, you have more than 1,300 publications got from the SEER database. By doing simple statistics, you can notice also that during the 70s, the 80s, the 90s, the output was very low. The real change happened in the past 10 years with the development of big data mining tools that could handle such huge amount of data. So if you look into one of those publications, you'd found the publication done on like 10 million cases or something like that. In addition to that, the data of the SEER database are publicly accessible to all physicians anywhere in the world. So if you can think of what is the country with the most publications done on the SEER database of the United States, can you guess? Not in the United States. China is the first, is the biggest country where around 50% of the publications based on the SEER database are coming from China. So data are available for all physicians. I have a colleague that have published many publications on the United States data while he is in Egypt. That's a very important point. And as you can see from this graph, how these data availability policy have revolutionized how we can understand the cancer trends, the cancer survivals. The last story were based on one of the unknowns in our handling breast cancer patients. Well, we can ask ourselves, what are the most common risk factors for breast cancer in Egypt? So what are the risk factors of breast cancer in general? If you open the book, you'd find typically genetics. Well, if you treat breast cancer patients, you will find that even with doing the most well-developed germline tests, you will find less than 10% of your patients are carriers of any specific genes. And the majority of them even doesn't have family history of cancer. Nulliparity, well, that's another cause or another risk factor in the book. But I can assume that like 99% of my patients are multipers. Non-lactation, again, in the book. I can assume also 95% of my breast cancer patients are lactating or did lactate. OCPs for more than 5 years, that might be a cause. But again, most of my patients did not use OCPs. Smoking and alcoholism, they are significantly associated with breast cancer. All of my patients, and I think of yours, are non-smokers and have never drank any shot of alcohol. Radiation exposure, some of my patients, like 1 in every 1,000, might have been exposed to radiation therapy for a mediastinal lymphoma, for example. But again, 999 of them weren't exposed to any radiation therapy. Benign lesions, well, most of them didn't have. Family history, again, the majority do not. Obesity, well, that's an observation that might be okay. Obesity, we find from very small center studies that breast cancer patients are a little bit more obese than the controls. And the two commonly stated factor, early menarche and late menopause. Well, those are non-modifiable factors, but around half of our patients, they present before the age of menopause. So, looking into that is impossible without having access to big data for breast cancer patients. And I would here close my presentation with how we did handle the data of the first 2 years of the breast cancer screening initiative. This presentation was presented 2 weeks ago in the past ESMO, and there was a great team behind that, led by Dr. Hamdi Abdulazim. I had the honor to present that, and it is, as clearly mentioned by Dr. Ahmed Mursi, the project started in July 2019 nationwide. More than 3,500 primary healthcare units did handle the data, and we reported the first year data of 10.8 million women who presented to those centers. Again, the primary healthcare units are available everywhere in the 27 governorates of Egypt, and the idea of it is doing a clinical breast exam to the ladies who were likely to have breast cancer. And by likely, we didn't know the reason. Again, I've just explained how we looked for it, but we've compiled some risk factors as from the ones I've mentioned, but those were associated with the highest risk in the Gale model. That's a UK-based model. So if the lady had those risk factors and she's more than 18 years old, we'll give her one clinical exam. If she's more than 35 years old, irrespective of the risk factors, she has the clinical exam. If it's normal, then she goes home and she's instructed to come the next year. And if the examination is abnormal, then she is referred to a cancer care clinic. That's a tertiary center where all they have a breast surgeon, breast oncologist, and mammosonography machines. All the data were stored in a central MOH server that collected all the data from all the data points from the primary healthcare centers, the tertiary centers, and even the treatment data. Out of the 32 million ladies that were target of our screening program, again, 10.8 presented at the first 2 years, 5.9 million of them were candidates for screening. So those who were more than 35 years old or less than 35, but with risk factors, again, let's note that around 7% only were less than 35 years old. So abnormal clinical breast exam was detected in around 1 in every 10 of the women examined. They were referred, and 390,000 of them presented to the tertiary care and had their second exam and possibly mammography and sonography. And of them, around 200,000 women did mammography and sonography. Here we did diagnostic imaging, so it's either mammosonography or sonography alone if she was very young, where the mammography is not useful. So the majority of them were compliant to the imaging, and out of every 10 mammographies done, approximately 1 of them were suspicious, so was referred for biopsy. A total of 10,000 biopsies were done, and 5,335 cases were diagnosed with cancer, which is around 89 per every 100,000 exam, which is very close to 1 in every 1,000 ladies examined in the primary healthcare site. Thus, the median age was 53 years. That's around 9 years younger than the US screening data. 5% of the ladies were diagnosed below 35 years old. And for the staging, we have the data of the clinical staging that's based on clinical examination and the radiological examination, mammography and sonography data, and stage 0 to 2 are around 20% of the whole population. Of course, some of the 80% might be upstaged when doing further, for example, CT scans and PET scans, yet this coincides with the WHO Pillar 1 criteria that was mentioned by Dr. Ahmed. In addition, we've tried to answer the question of the risk factors. We did like a huge case-controlled study to check the differences between the ladies who were diagnosed with cancer versus those who went out with a normal exam, meaning that they are a true control. In our data set, again, of millions, we have the body mass index having almost 60%, body mass index of more than 30, so definitely obese. They have a 60% risk to have 60% more risk to have breast cancer compared to the controls. We have those with diabetes mellitus, which might involve a whole metabolic syndrome involvement into the breast cancer incidence. We have the age of menopause of more than 50 years for those who are menopausal, and we have, of course, the family history of having breast and ovarian cancer, and those who went for prior breast biopsy for any benign lesion. We concluded that the clinical breast exam is an effective tool for downstaging breast cancer, and it is a possible alternative for countries with low or middle income countries that have limited access to screening mammography. They could have that as a minimum requirement for breast cancer early detection. Out of that, we have concluded a large data set of breast cancer patients and healthy controls that could give us access to many unanswered questions in the breast cancer literature. I'd like to thank the whole committee who did a great work in every step of the project, where the conceptualization of the idea, designing of the database, doing the whole process of data, long, tedious process of data collection, data management, and of course, it's support by the MOH. And thank you very much.
بكره يعني بجد والله phenomenal outstanding experience الصراحه يعني. And now the floor is open for any questions.
Thank you very much, Dr. Lai. Actually, I missed the most important message. What was the incidence of detecting breast cancer in the whole population you screened?
So when we do a screening test, we check for the cancer detection rate. Out of every 100,000 women, the number of breast cancers were 5,335 women. Out of 5.9 million ladies examined, out of 10.8 million ladies who presented, and out of 170,000 mammosonographies done.
Yes.
And out of 10,000 biopsies done.
It's clear. I think it's without calculation, it's cost effective. Now, who did the clinical breast exam? Were they highly experienced surgeons?
No.
Because you know that the clinical exam has its limitations. And sometimes with a huge breast, you can miss very easily an evident disease.
Well, that's a very important point. Those who did the examination were female healthcare professionals, general physicians, or trained nurses. They had a hands-on training on breast exam that lasts for a few hours, in addition, of course, to their medical degree. But that that's very important, that it's allegedly a very non-sensitive test to do the clinical breast exam. But one of the major problems that here we face in Egypt, that most of the breast cancers, according to a meta-analysis done by our group as well, were diagnosed in stage 3 and 4, meaning that they were diagnosed at a very easily palpable stage. According to the mammography screening program done by the MOH in the past 10 years, the half of the breast masses that were of breast cancers that were detected by screening mammography, that was a screening mammography study in Egypt. Half of this of those tumors were more than 3 centimeters. That's totally different from the US screening data, for example. But this is to show how deep is the magnitude of the problem of late stage in Egypt. It's 60% in stage 3 and 4 in the meta-analysis done over the past 10 years.
But this is actually a very, very important, and it's a very good point, because it was what Dr. Luai said, gave us a chance that we can start with the current infrastructure that we have, with the current GPs that are spread all around Egypt. However, today, after 4 years, we are able to claim that they are very well trained, especially the nurses, because they don't move around. But we're going to face a challenge in the coming years, that you're going to need more accurate examination, or you're going to need more accurate modality. And this is what we're trying to set. This is why we're trying to do the enhanced palpation methodology, or we go directly for the standard of care of screening mammographies if the infrastructure allows. However, it's a really important point, and it's very important for the sustainability of the program. This is why we keep training all the time, and we keep redoing the training, and it's led by Professor Yahya Safwat. However, there are more than, I think, 500 people involved in the training, with Dr. Ihab was the head of the whole program for the initiative training in the MOHP.
Thank you very much. May I have another question to Dr. Khalid? Unless you have a comment.
No, I have a question.
Okay. Okay, thank you very much, Dr. Khalid, for your nice presentation. Actually, it's a difficult question to answer, but I have to say it. Is there any quality control program to minimize mistakes using the artificial intelligence in the field of oncology?
Not that I'm aware of, but this is why I am saying that the era of artificial intelligence has been used a lot in drug discovery. Okay, so this is not something new, but the idea is it's a tool that we have nowadays that is extremely interesting. Why? Because it is based on experience. When I say that a pathologist or a radiologist or a clinician is able to say that he is an expert because he saw 1,000, 2,000, 100,000, 200,000 patients or slides or whatever. AI can see millions of data. It's whatever you input. It can be the experience of these virtual persons that we see. Again, we don't know how much error there can be, and we know that there are errors. I saw you the image of the image generation, for example. But again, this is why I emphasize a lot that we can use it now within the context of a study, one, and within the context of suggestion, that it can suggest to us. At the end of the day, the human factor will be the one to finalize the diagnosis or the decision.
Do you expect that works nicely in our face-to-face interview between the physician and the patient?
Yes.
Works most of the time positively of the treatment plan. Having such kind of interview removed from the physical exam, from the treatment plan. I'm sorry. Like I said, it's a community trend, or now the patient wouldn't be convinced that he has been checked nicely unless he got interviewed face-to-face by the treating physician, getting a complete physical exam. Then he starts to trust the physician and follows his instructions. Removing such part of the relation, don't you think that it would affect negatively the treatment plan?
Totally agree, and this is in none of what we suggested was the idea of to remove this communication, but the idea to facilitate and keep this communication open 24 hours between the visits. Let me tell you what AI can do and what is going in the pipeline now. What is going in the pipeline is an AI software that can listen to your conversation with the patients and can take all the data that happened during the interaction for 20 minutes and put it directly on the electronic health record. So just by listening to the conversation and putting, this is ongoing software that are happening. So is this eligible to our culture? I know that we have a very strong program for وزارة الاتصالات that is working on the natural language that is coping with the Egyptian dialect of Arabic. Actually, if you go to ChatGPT and you ask him to translate the text from English to Arabic, he will translate it very well. But if you ask him to put it in Egyptian dialect, he will do it even better. And you can try it now. As we speak, you will see an amazing result. So yes, but again, he needs a very, very well controlled environment because we still don't know the magnitude of errors. And this is the major drawback of this technology.
Thank you very much.
If you excuse me, my dear friend Dr. Ahmed, you have mentioned a statement within your talk about ربنا يستر إن شاء الله, about the benefit of the medical facilities regarding the presidential initiatives. We all understand that the patient is the side who will benefit from this work, this huge work. The floor, I think, need to be clarified how the other side, the hospitals, the medical entities, the health providing service will benefit from the work of the initiatives.
Okay, so the question is, we talked about how the patient will benefit, which means the community will benefit.
Yes.
Which means we talked about how the country benefits.
How be the tool of the upgrading of the health providing service.
So when we were saying that the Universal Health Authority or insurance is the target, and what we do is what we upgrade the infrastructure. So you want to understand? Okay.
How we will work to improve the manpower, the infrastructure,
Okay, so
and the abilities.
one of the things that we talked about right now is that we have made use of the nurses. We increased the capacity of the primary health facility. The primary health facility is a basic unit that's available everywhere. And it's being upgraded also through the initiatives, not through the cancer initiatives, but through the initiatives that will have an X-ray, an ultrasound, and a small lab. So if you have this facility, with the most important factor is a trained human being. This is a proven, cost-effective method of decreasing the burden on the system, decreasing the spending, the public spending on treatment, and delivering the service fast in adequate way to the patient. This is one of the aspects. The second aspect is that we have to be able to see our challenges, and one of our challenges is you cannot, if I asked you today, Dr. Ihab, do you know what are the defects that we have in, for example, the infrastructure for colonoscopies? You would have an idea. You might have numbers about a region. You might have a great idea about a center, but you cannot give me a complete picture. So what we do usually in the first year for the initiative is that we see the picture, and you see the pictures through the service. So for example, we thought that we were going to have a huge problem with cancer prostate, and we found that it's the best infrastructure available for diagnosis of a cancer in Egypt. It might be even a little bit comparative to the breast cancer infrastructure now. However, we have a terrible infrastructure for lung cancer. So you take this data and you start giving each sector in the government responsible for a sector the data that they need. So you go, for example, to the SMCs and you tell them, you need this machines, you need this, this human resources, you need to do training in this. You try to talk to the fellowship to create, what we did, by the way, with the NCI is that we're creating a molecular pathology master's degree, because we have a lab, we don't have capacity of human resources, to serve the lab for the coming 10 years. And the thing about the initiative is that you look from a state point of view, which is nothing called centralization. You cannot have the service in one place. It has to be standardized. It has to be decentralized. It has to be accessible. It has to be affordable. These are the main aspects of saying that you have a service available and you succeeded in it from the government, from the state's point of view. So for the hospitals, you increase the infrastructure in terms of machine, but you also increase the infrastructure in terms of human resources. Today, after 4 years of the initiative, you have seen junior physicians who are able, for example, I'm not going to talk about medical oncology. They know how to do breast conservative surgery because it was not on the table before. And this will affect the whole service delivery for the whole community, whether public or private, under a universal health insurance or in the same system. So you do change this. The second thing that's very important, and this is why the program proved to be cost-saving, is that standardization decreases chaos. Chaos spends more. So you think, for example, that, okay, we can't afford this medication, we can't afford this procedure, we can't afford this imaging tool because we don't have the money. And when you look through details, you find that anything that costs less, for example, than £5,000 are abused, extremely abused. So when you do standardization, when you do follow-up, when you do auditing, this is why the initiatives proves to be cost-saving. This is a good example. However, for example, in virus C, the ROI is 400%. For the one for the hearing aids, around 350%. So the idea of initiatives itself, it's not about only that you have to be cost-effective. You're upgrading completely the system. You're changing the healthcare system, and the most benefit is going for the junior physician and the junior nurses and the junior, even that now on the table, a lot of people are asking about the healthcare management. And we're thinking to have it implemented as a degree, an academic degree that you can give.
This means that you are collecting data, analyzing this data, and building your decision according to the results of this data. And according to my specialty, I am a gastroenterologist. I am proud that in one of our hospitals, in Abari Hospital, I have received a call phone that the staff there are going to do an ESD procedure, which is a very highly talented and complicated procedure for a patient diagnosed within the initiative as a case of cancer colon. This is our target, the message that we want to deliver to everyone, that this initiative is a beneficial for the population, for the screening of cancers, and for the Ministry of Health and Population and other facilities introducing, and Ministry of Higher Education hospitals, that it will act as an a crucial upgrading tool for this service and for this infrastructure and the human power for the training and education, unified guidelines, unified guidelines everywhere within the the country, so that the patient in Aswan will be treated the same as the patient in Alexandria, the same as New Valley and in North Sinai. A very great effort, Ahmed and your team. I hope the next year and the year after, we are discussing applications and results that we are very closely to start, and we are ambitious to look for this data, our publications in very high international journals, to say that yes, we can.
Inshallah. Thank you.
Any other questions from the floor?
Raising different issues, actually. And my question, actually, to Dr. Ahmed. Can we go side to side searching for early disease that we might be looking for a biological marker that can detect the disease just by a blood test?
Okay, so after we do the basic infrastructure and we show the world that we are able to at least do the first step that everyone now is done, which is that we have screening campaigns. We have we have early detection, super selective early detection campaigns for 6 cancers. We were able to convince our partners in Europe, and Dr. Hisham is working with another partner in the US, that we go through exactly what you suggested. So we're working on a program called Interception. Interception is a program led with the French government through Gustave Roussy. And the basic idea of Interception is trying to predict the possibility or the percentage of having a cancer in a member of the community through analyzing their genetic structure, their phenotype, their genotype, just by a blood sample. There's also a lot of data about the circulating DNA that still at this point are mainly looking at through the follow-up of the patient. So you follow up the patient either after the adjuvant phase or maybe in the metastatic phases. Instead of doing a lot of images, what you do is that you keep following through a blood sample. But there are many programs and many papers and research towards this. And I think that what we need to do now in Egypt is to have the infrastructure ready. So when the data is out, which might be next year or in 2 years, we are ready to do this, because this will be highly cost effective and it will be very easy to do. So it's again a great suggestion. Thank you.
But you are collecting blood samples from the start, from day zero. You are collecting blood samples.
We didn't start yet. What we did is that we built the infrastructure. We have a lab in the MOH, and we have a lab in Ain Shams University. And what we're trying to do is that we're trying to make these labs operational. We're making them ready. We're trying to have human resources ready for this. I would think that we can start working in this program by July next year.
But you have just lost the population you already checked.
Well, this population did not exist, so we did not lose them. We have them. What we're going to do is that at a certain cutoff, we're going to start this program. However, everyone in the system, everyone of this population is in the system. You can recall them and you can work through them.
I have just one comment to clarify to the audience that there is no that screening for cancer through blood tests is not yet approved and is within a research platform only. So that is a study and not a program. That's not a functional program that could substitute any evidence-based screening or early detection programs that are already implemented.
No, we know this. We know this. But what we are discussing right now, the Egyptian population, you might find something unique just through a blood sample. You got positive results, negative results, and you compare to the clinical outcome. It's as simple as that.
Yeah. So what we're trying to do, again, as the slide showed, we try to do a complete, it's okay, thank you, sir. A comprehensive genetic profile for the patients. What we're trying to have, we're looking at every patient that is diagnosed as one of the 6 cancers that we're screening for at this point, which is breast, colon, lung, prostate, HCC, plus or minus cervix. We would try to do a comprehensive genetic profiling of 500 genes. It's very costly, and it's not part of the government spending. It has to be done based on grants. We are receiving grants for it, but our aim is to reach more than 20,000 per year. Now we are able to do around 1,800 only per year. So we're in a very primary phase of looking into this. However, in my opinion, we have to start looking. So by next year, we can show some data. I mean, I can tell you that before the year starts, we will have certain amount, at least around 10 to 20 cases before the year starts, that will have a complete, comprehensive profiling done. But then I will have another question. What will we do with the data? Okay, I've done this, it's there. Do we have the mindset and the capabilities and the research group ready to use the data? The data usage is a major question that we have to start thinking about. And in my opinion, this should be led completely by the universities, because at this point, it's very research, very academic. Of course, the whole scientific committee are professors from the universities, but it's time to start thinking, because it's very good to start with the endpoint, start with what you want, and then we build the infrastructure to answer what you want. And this is what we were doing with the questionnaire in breast cancer. This is why we were able to have certain answers that were presented, and again with the other. دكتور عماد عندك سؤال؟ ما عندكش سؤال؟ معدي. عندك الإجابة. Okay.
So I'd like to thank you very much for organizing this session, and thank all my chairpersons, and thank you very much for your attendance.